Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Farden, and I organise Grand Rounds here in Dundee. Welcome. This week is SAS week, a week in which we celebrate the roles that our specialist doctors and associate specialists play, the vital role that they play in NHS Tayside across Scotland and the UK. I think my personal reflections on the SAS grade of doctors is I've always been a bit confused. I have to probably be honest and say, what is the difference between what an associate specialist, a specialist doctor, what is a staff grade? Is that a term we should be using? And I think there's a lot of confusion and a bit of smoke and mirrors about what goes on. But what I do know is that being a specialist doctor, that not in a consultant post and not in training, can be a rewarding role and is an important part to play. And I think that in the current climate of recruitment and retention and training, that we should be looking at what Vinita has described as a paradigm shift in SAS professional development. And this week is the week where we highlight that and turn our lens to focus on that. Now, Vinita Shekar is a specialty doctor in oral and maxillofacial surgery. She holds a number of senior roles with Royal Colleges and austere organisations to promote the SAS doctors. And she is here to speak today about a paradigm shift in SAS professional development. If you have any questions, please put them into the chat and we can ask at the end. Vinita, thank you so much for coming along. Looking forward to hearing your talk.
Thank you very much, Tom. And it's a privilege and an honor to be here today. So I'm not surprised by the fact that you said that you're surprised by the fact who are specialty doctors, who are associate specialists, and I will touch upon that a little bit. So first of all, something about me and my educational background. So I'm international medical graduate from India. I'm a fellow of Royal College of Surgeons of England, and I have done this fellowship assessment. I did take my membership exam. I have legal background, so I've done my LLM in legal aspects of medical practice and held a number of roles over the years, complementing my education. I have got PG cert in medical education for surgeons and PG cert in IV sedation, so I do provide sedation service for our maxillofacial services. And I can say best choices I have ever made, just because where I am is entirely because of my background. Next slide, please. So something about my career. Now, I use this slide not to show what I have done, but for my SAS colleagues to acknowledge that there are opportunities out there if they wish to use them. I started small. Year 2 of my specialty doctor job, I started as clinical audit lead. And from there, I became SAS rep on the local negotiating committee. The day after I graduated from the law school, I became a whistleblowing advocate and investigating officer for doctors in difficulty. I have experience of being member of M&M steering group at NHS Tayside. I started in Tayside as clinical governance lead, and following that, I did the national role of being SAS rep on my own association of maxillofacial surgeons. Now, I have to say, while I started small, one role led me to another. And one national role led me to several national roles. So today, my present roles include I'm SAS Education Advisor for all SAS doctors and dentists in NHS Tayside, and we are about close to 130. I'm chair of SAS Committee of Royal College of Surgeons of England, and that gives me a place on the council. I co-chair the SAS Committee of Academy of Medical Royal Colleges, and that again gives me a place on the council. But the academy role also makes me the SAS lead for all SAS doctors, surgeons, dentists in all 4 nations, no matter what specialty they belong to. So my background is quite vast. My work I do is quite vast at a national level. And I'm also deputy secretary for LNC at Tayside, taking on the full form of secretary role in November 2023. Next slide, please. So just going to touch upon the SAS workforce data. Now, before I touch on this, I'm going to just respond to what Tom asked before. So SAS stands for specialists, associate specialists, and specialty doctors. And this has been changed just this month. Before this, it stood for staff grade, associate specialist, and specialty doctors. Reason being, we had 2008, a big change came in 2008 where the old SAS contract got changed into the new, where they took away the role of staff grade and associate specialist. Sorry, go back to the previous slide, sorry. We changed it to the new contract where, sorry, another slide back, Tom, I think the slides are jumping.
Sorry, there we go.
No, that's okay. So in 2008, the contract came where the specialty doctor role was introduced. Before that, we were known as staff grade and associate specialist. Now the staff grades have completely phased out. So we do not have any staff grades in the country, all 4 nations. What we have is associate specialists who are decreasing in number by the minute as they retire, and all new appointments are specialty doctor or specialist doctors. To be a specialty doctor, you need to be 4 years post-graduation, and 2 years needs to be in the specialty you're appointed in. Whereas for the specialist role, you need to be 12 years post-registration, and you need to have 6 years in the specialty you're being posted. So these are fairly new contract. The specialist contract has come out only 2023 in Scotland, but other 3 nations, it was introduced in 2021. So that's the difference in different things, and we can go along a little bit more as we go. So just going to touch upon the workforce data. I'm sure some of you have seen the GNC Workforce Report 2022. It shows exponential growth of UK medical workforce. And it is a changing medical workforce largely driven by recruitment from overseas. We have increased in number of the international medical graduates, which to my surprise, when I first read the report, was 40% compared to 10% increase in the UK graduates. If you look at the new registrants, international medical graduates make up to 50% compared to UK graduates of 39%. And this growth is going to go further. By 2030, we are hoping for another 1/3 growth in this medical workforce. And if we don't appoint international medical graduates and we go back to pre-2017, we will be 23,000 fewer doctors in 2030. And this highlights the importance of international medical graduates to the UK workforce. Next slide, please. So again, working on the same figures, these are the figures if you divide them into different categories. So when it comes to the general medical practitioners, there's a 7% increase in the growth. And it is significantly lower than the overall growth in the licensed doctors of about 17%. 11% increase in the growth of consultants with wide variation across different specialties. So specialty like maxillofacial surgery, we have smaller because it's a smaller one. But if you look at the general surgery or orthopedic, you might find there's a huge increase in the growth of consultants within this 11%. 17% increase in growth of doctors in training, but we look at the SAS doctors or locally employed doctors, which are mostly clinical fellows, there's a 40% increase. And what GMC is predicting is if the trend continues by 2030, SAS and locally employed doctors in secondary care will form the largest group, approximately 66% in the medical workforce. Next slide, please. So that's quite alarming. That just shows the shortage of workforce within our country and how we are unable to fulfill that requirement. Now, this is a silent workforce. So SS workforce is a silent workforce with untapped potential, who with a relative small financial investment can contribute significantly to service configuration and enhance service delivery. But for that, clinical leads and medical leaders within the hospital, they come in place where they have understanding of service issues, they have ideas for service development, they can encourage training of SAS colleagues and enable the service development. So it is really in our control how we look at the workforce and how we look at the service development. Next slide, please. So just going to touch a little bit on the Scottish SAS development program and what it is for, what it does. It was founded in 2012 and it aimed to access the diverse and changing needs of SAS doctors and dentists. It offers national funding for developing new clinical skills. It provides guidance and supports training towards application for a CSER. It enhances our roles within our clinical teams and supports the SAS workforce to thrive and contribute to best patient care. We get approximately 500K per annum, and I'm quite pleased to say since 2012, we have not lost this money. This has not gone down, while we are hoping that it will increase in the future. Next slide, please. So structure of this program, it is overseen by a lead dean within NES. It is supported by the general manager for NES Medical Professional Development Workstream. It is chaired by our associate postgraduate dean for SAS doctors and dentists. It has board membership from NES, DME Group, BMA Academy, and we enable collaborative working on key areas and challenges within 4 nations. I wear 2 hats on this. One is by the education advisor for NHS Tayside, and I also wear the Academy hat representing Academy's SAS committee. And we do have program coordinator who work with all SAS education advisors in each health board. Next slide, please. So we have P allocation, nothing comes free. We do get paid for our time, and you can see we have at the minimum of 0.5 PA. The PA allocation depends on the number of SAS doctors and dentists. On average, for every 100 SAS doctors, we get paid 1 PA. And if we think if the number is more and if you need more, we can bid for more. And you can see 120, I find 1 PA is quite okay for me. So I have stayed on 1, but in some health boards, we have 2 or 2.5. That just shows a larger number of SAS workforce in those health boards. Next slide, please. So types of applications we support: qualifications, training courses, top-up training for Caesar. We do offer secondment for additional experience, and training courses and secondments. Now, what are secondments? Secondments is, say, for a candidate who is hoping to do Caesar, has identified a gap in his CV and he wants to go out, or within the health board, he wants to become a trainee for 3 months or 6 months. We can offer pay for the locum recruitment for that person so that the SAS doctor can go out, get those trainings and fill the gap within his portfolio for Caesar. So we do pay for the secondments. Next slide, please. But there are certain priorities for the program board. So those are hands-on procedural based training. We do recommend that these funds should be used for experiential supervised training secondments, upskilling through training where SAS grades can take on responsibility for delivering clinical services and procedures, particularly in clinical areas under the most pressure or where the recruitment can be a bit difficult. And it should be a training that leads to their autonomous practice. I generally call it independent practice. I don't believe in term autonomous practice because none of us actually work autonomously. We are working in multidisciplinary teams relying on each other. Next slide, please. So if you look at the trend among applications from the last few years, you can see that large number has gone towards post-graduation qualifications and the training courses, and a small amount has gone towards the other areas like Caesar or non-Caesar additional training, accredited training programs, or supervised training for experiential training. However, the Caesar when we allocate funds for the Caesar are expected to be more expensive compared to the others. So there is no cap on how much one person can apply for if they can justify. I know that last Caesar applicant from Tayside, we offered about £80,000, so it's a large amount. So it is up to clinical leads to identify what they can offer to SAS colleagues, and training can be provided and funds can be allocated to the departments if needed. Next slide, please. So there is a difference in study leave and new funds. New funds are the SAS education funds. I generally tell all my colleagues, SS colleagues, when they ask for money is, have they used the study leave? And I say study leave is supposed to be for me. If everything is about me, I maintain my current skills using the study leave budgets, keep my CPD to remain up to date and upskilled, and my CV development as per my PDP for appraisal. However, the SAS development fund can be used for new or enhanced skills towards a Caesar portfolio or new service development. And we do need support from the departments, TPDs, and the college sometimes if we need to prove that that training is needed. Next slide, please. So we have done impact analysis, asking feedback from the clinical leads who have supported these applications, and most of them say it's value for money. It contributes towards professional development and professional progression of SAS doctors. At times, it does contribute to new service, and overall, it is a better quality of care for patients. Next slide, please. So the range of educational resources providers for the SAS doctors, there are a huge number of them, and I always encourage all my SAS colleagues to look wider rather than just what is provided locally within the NES. So there are free courses and workshops which we have in the health board. Most of them are towards professional development, like leadership courses or other things we can organize. NEST provides large number of educational resources. Individual specialty associations have some courses which come as part of the teaching program for their members and fellows. Royal College, we have lots of resources, and happy to do a separate webinar at some point, Tom, if you like, in regards with what Royal College offers and what it does in the backgrounds. And same goes with Academy of Medical Royal Colleges. We have lots of SAS relevant resources in Academy's SAS website, and would encourage somebody should go and look at those publications and recommendations that will show the majority of our work, what we are doing with medical workforce leaders within England and other nations. Medical Leaders UK, before they were known as National Academy of Clinical Tutors, they have lots of resources. They do offer workshops and courses for educators. And then BMA and BDA obviously have lots of courses, and so it goes with the Defense Union. So I think it is important as colleagues look at all these resource providers to say, do they really need to spend money before they come to us for money? Next slide, please. So opportunities within DME office, we have lots of opportunities provided by the med school, and most of them are for trainer recognition. I think that's something I have used, and I have put down something I am aware of. So there are staff development workshops for medical educators, teaching skills, supporting learning and assessment, core skills, mapping to the GMC criteria for trainer, and I would recommend all SAS doctors should be trainers, just like all consultants are expected to be trainers. We do have master classes and other places, and I have added some contact points for people to approach, and or a website where you can actually book the courses. Next slide, please. So point of contact for any SAS doctor or dentist in our health board, it could be me as education advisor. It could be SS reps for their own specialty councils. It can be SAS representatives on college SAS committees, SAS representative on LNC, and director of medical education office who would be able to signpost people in appropriate directions. But overall, I can wear separate hats of health board education advisor, LNC, our college SS committee, or any college committee, because all the leads of colleges do sit in our SS committee of the academy. Next slide, please. So common challenges. There are challenges for SAS workforce, but I generally say those challenges are common, not just for individuals, but also for the department. Number one is variation in experience. When you appoint a specialty doctor, you do not know what they have learned in the last job, because what exposure you get in each department varies from one health board to another, one trust to another, and one specialty to another. So it is important specialty doctors define their goals and their roles. They take ownership of their own training. They develop direction and decision-making, enabling their progression and being their own ambassadors. But it needs teamwork and collaboration at department level. So I think it is always a good practice for department to have a governance structure when it comes to specialty doctors, so that they know who they can go to if they need help, or if they need support with the training and progression. Because don't forget, they're 4 years post graduation in the first year of their post, and obviously they do need training. So I don't believe when they say trainees need training, but you're not a trainee, I'm not responsible. That's wrong, because everyone needs training, even consultant level and senior SAS level. We all need training because medicine changes, and this is a digital world where now we are learning. Experienced surgeons are learning how to use robots and things. So learning goes on all our lives. Next slide, please. So for my SAS colleagues, I asked this question: how do I plan this journey for myself? Next question, please. And this is what I say: job plan. First thing is learn your job. Job planning, I often hear from my colleagues, is that I do not have a job plan, or I do not have an agreed job plan. I generally say engage, I think if you do not have an agreed job plan, it is our own fault because it is our job plan. So we need to engage with a clinical lead. If there is some kind of trouble, we can always get further support from immediate colleagues within the department, SAS education advisor, which is me, SAS rep on LNC or BMA rep on the LNC. There's a lot of support out there if there's a trouble with the job planning. So job planning is the first step because it gives you a direction towards your appraisal and your PDP. Next slide, please. So this is kind of little touch on specialty doctor contract 2008 and 2023. I say understand and learn terms and conditions of your contract. I have added the link for everyone to go and have a look. I say use the purpose constructively, learn the person specifications and generic professional capability framework that has been introduced to the specialty doctor contract 2023. Most of us has migrated to 2023 earlier this year, but there are still a small number who are still on 2008. For those on 2023 contract, must use GPC framework during appraisals and job planning and provision of your PDP because it will prepare you for the specialist grade post when you are ready for it. So please do build up on early in the specialty doctor post, and I have added this link for GPC framework, which is expected of us, and be ahead of your threshold requirements within the contract. Next slide, please. Specialist grade 2023, learn the contract early in the specialty doctor post and develop as expected of you if applying for the specialist post 10 or 12 years down the line. Learn the specialty specific notes. Again, I have added the link, and learn the concordat between Royal Colleges and MSS employers to understand the college role in appointments. Now, this actually applies only to 3 nations at the moment. Scotland does not have to have approval from the college just yet. However, we do not know what the future holds now. So it is kind of some space we have to watch to say what decisions have been made for Scotland. Next slide, please. So GPC framework, similar to what trainees have, and this has got 6 domains. And at the end of our specialty doctor post, when you're prepared to apply for the specialist post, you should be able to fulfill all these requirements. I'm quite glad to say that I was part of development of GPC framework representing Academy, and I was part of the task and finish group with the chair of Academy at that point, who is our very own consultants in Tayside, Dr. Carrie McEwen, who's also chair of GMC currently. Next slide, please. So specialist grade 2023, we must remember if you are advertising for a post, which I hope the departments will soon, there is no requirement for the candidates to have a CCT, a fellowship. They do not need to have a presence on the specialist register. They do not need to have a locum experience as a consultant or a specialist, and they certainly do not need a CSER. So it is entirely the 12 years of experience and the portfolio career they have followed will lead them to the post of specialist doctor. And for that reason, I generally say departments should collaborate with the SAS teams to make sure they're trained the right way. Next slide, please. So what do I need to do to achieve it? That's my next question to my SAS colleagues. Next slide, please. And I generally say what I have generally done. So this has been my PDP over the years, which I have done. I've done much more than this, but these are just the wide titles. So just explore. There is so much information out there, and there are so many things you can fulfill. My rule for my PDP is 1 clinical, 1 non-clinical, and 1 personal, which I think in my personal work and life, professional life, it will help me. So always have 3. Don't have too many things on your PDP because you may fail to achieve them all. Next slide, please. So what can facilitate my training and my learning? Next slide, please. So e-portfolios, they are the educational portfolios provided by the colleges. Trainees do have access to that. And I'm quite confident that most of the colleges, other than a couple, give access to the SAS workforce as well. I think psychiatry still doesn't give, and I'm not sure if it's general practitioners because they don't have SAS doctors in primary care just yet. But I think we're talking about introducing SAS workforce in primary care in the near future. Keep your logbooks, make sure you do work-based assessments. and enter them onto the e-portfolios of the college. If they're good enough for the trainees, they should be good enough for the SAS workforce as well. Follow the curriculum and do the courses which are relevant to your curriculum, and certainly have trainer recognition, which can be declared on the GMC register as well. Next slide, please. So developing teachers and trainers in undergraduate and postgraduate medical education, university has the role, and you can be a tutor, senior lecturer, professor, or reader. You can be involved in undergraduate and postgraduate education. We are quite lucky that we are based in a university hospital, so there are lots of opportunities out there. So please do go and visit the GMC website. There are lots of information out there, and it can be replicated at health board level to become a recognized trainer. Next slide, please. So how do I interpret this as an evidence-based exercise? That's a question I often get asked when I speak to specialty doctors who are trying to mirror a trainee's journey to make sure that they get onto the CSER or enter the register by exam or any other ways. Next slide, please. So I generally say for SAS doctors, appraisal is the key. Engage with your appraiser and the appraisal process. Lead your own appraisal. Reflect on the learnings and failures, and be critical of yourself and build on constructively. And use the e-portfolio reports during your appraisal, because they are quite important. And appraisal is a very smart system. Actually, you can combine quite a lot of information in there. It's like your ARCP, what trainees have. Your appraisal is your ARCP. Next slide, please. So progression cycle should look like this. Progression is right in the center, whereas the other, it's like an audit cycle. So your job plan leads to your appraisal, appraisal leads to your PDP. And if you combine your e-portfolio or GPC framework tick box exercise, combining PDP and e-portfolio, you can actually negotiate your job plan, and in the middle comes the progression. And I can assure you in 10 years, you're ready for CSER or for any other route of registration. Now, just to remind the audience here, in November, within a month, the legislation is changing, and the CSER will no longer exist. It is being replaced by alternate routes of registration. Again, happy to organize a chat by the GMC if, Tom, you feel that that might be beneficial for the hospital. Because it is relevant to all clinical leads or the consultants who may be clinical leads one fine day, and certainly beneficial to the SAS workforce. So there are alternate routes of registrations coming where some of the qualifications from abroad will be recognized, and they can be used to enter a specialist register or GMC register. You do not necessarily have to take the PLAB or any other exam. Next slide, please. So this is, again, another question I get asked quite often. They say, I don't have an opportunities for leadership and management. Next slide, please. And my response generally says, I cannot believe that. There are lots of opportunities. And no matter what you do, nothing is too small or too big when it comes to the management opportunity. So you could be a rota master, clinical supervisor, or educational supervisor. You could be a clinical audit or governance lead. You could have representation on various committees, or you could be an examiner. You could be an appraiser leading a committee within the department or outside, or the senior management roles, like many colleagues who might be listening today. So there are lots of opportunities. It's a question of just thinking outside the box and seeing what you think you are. My belief is everyone is good at something. It's a question of recognizing your niche and doing well on that. Next slide, please. So there are regional and national opportunities. Again, I have done quite a few of these, and I have to say that they are all rewarding, and one must go for these roles if they think they have achieved a lot from the local roles. Now, small roles lead to the big ones, so start small. That would be advice. Don't straight go for the regional or national opportunities unless you have had some experience in local management roles. Next slide, please. Leadership opportunities at the college. There are several. These are the ones I know that we have within our own college at Royal College of Surgeons of England. Speakers for webinars, conferences, SS committee membership, or the chair. You can be an examiner. You can be a course facilitator or a course director, and you could be a regional director for a small region, or you could be a nation director for devolved nations as well. So these are the various roles which college offers. Next slide, please. So in summary, coming to SAS project, it is now firmly embedded in the work of NEST, providing opportunities to develop the service further. We have as SAS educational advisors and SAS grade themselves, and we have shown ourselves to be integral to the success of this project. We have approval of funds for this year, 500K. I think our year runs from March to March. We aim to align the opportunities provided to meet the needs of both SS grades and the service in the next financial year and further in the future. And we continue to champion a blended learning approach with both teaching and experimental learning, aiming to maximize the benefit of funding for the successful candidates. And we have abundance of educational resources and professional development opportunities within Tayside and beyond. So that's kind of end of my presentation, but I'm happy to answer any questions. I have tried to fit in a lot because I've tried to fit in my local experience, my regional, national experience, but there's lots out there and I can talk for days if I'm asked to. So I'm happy to answer any questions, any other grand rounds, anything you think, Tom, will be useful, happy to come back and provide further information on that.
Thanks very much. That's really, really helpful, and I think really very clear. And so I think, you know, my introduction shows my ignorance of what even the titles are, and you very kindly pointed that out to show. And I think there is a bit of, we're just not really aware, are we, in the consultant workforce, this is all happening, and this is really important that we understand how it's happening. Now, if I change hats a little bit now to my postgraduate training associate dean hat, we know that there's a huge exodus of trainees, particularly homegrown trainees, who are leaving, and that you've highlighted that the international medical graduates are coming in to take those roles. And of course, specialty doctor and specialist doctor roles are not just for IMGs, they're not just for people imported into the system. And when I speak to exit interviews with trainees who leave, they often say the reason they're leaving is that they don't want to be a consultant. They don't see themselves as a consultant. That's not a role that's attractive to them. And they often cite that they want to be a staff grade in their terminology. So a specialty doctor with a pathway to become a specialist doctor, if that's what they want to do. Why is this not a more trodden paths? What do you think we need to do to mean that that people who come through the early start parts of training have this as a viable option to go into, that's not seen by them as being a lesser path or a failure? Or what can we do to promote this and get more of these roles?
So there are a number of things. What you have just stated is not just you who has asked me. This was experienced at my first regional role, which led to national role. And at RTS England, I have recently worked on SAS strategy. So if many of you know, the Royal College of Surgeons of England is the first college who offered to have a very formal review of diversity of that leadership within the college. So I was part of the panel. It was led by Helena Kennedy, one of the human rights advocates, and she is part of the House of Lords. And we had different people, a team of people who are leading within their own areas, part of the panel. And I was representing SAS doctors and dentists in that. So we had 16 recommendations, and college adopted all the recommendations, and we've been working really hard for the last 2 years, making sure that we change, and we have changed a lot within the college. So I would highly recommend that please do read the Kennedy report and what college has done. College has its own micro website, equality and diversity and inclusion website, and I'm the first one to publish on that, our SAS strategy. We had over 45,000 clicks in the last 1 month. So it's becoming very popular. Other colleges are leading on that. And my recommendation is, if you want to see how you can promote the role of SAS doctors, the education starts at the grassroots. Our med school needs to have representation of SAS doctors teaching in those groups. And also on the career days, you need to have an SAS doctors coming and talking about the career being as SAS doctor, what it means. And to have positive role models for that, because it is a positive career. If somebody gives me even a job of consultant, I wouldn't take it because I'm pretty happy. I earn as much as a consultant, and I have my work as a portfolio carrier as much as like a consultant. All consultants have portfolio careers these days because we are all subspecialized within our own specialties. We don't do the general work we used to do 20 years ago or 10 years ago. So I think we need to start at med school career days where you have an SAS doctor coming and talking. Career fairs, you could have a team of SAS doctors who could have their own stall showing flavors of different specialties. And then I would ask our medical workforce leaders within our health board to do review of diversity of pay site, because unless you have SAS doctors on the leadership positions, you will not be able to solve this problem. So you need to have diversity, because you know that when you have a diverse group, the learnings are much more than having the same group of people. So our English college, you will see in that is, it was known as a club, which is made of middle-aged English white men. But now it's not the case. We have changed. Our face has changed. And if you come to the college, you will feel the difference. So I would highly recommend visiting the college EDI website and learning about the candidate review and the work we have done following that. And if our health board wants to be the first one in Scotland to do something like this, I'm happy to offer my service and help.
Thanks very much. Does anybody in the audience have any comments or questions that they'd like to voice, pitch? I think you've stunned them all into silence, so that's excellent. So Vinita, thank you so much for coming to Grand Rounds, and I think that's been really valuable to us. I don't see many of our trainees in the call right now, but I do know that many of the trainees watch this on YouTube later, so I hope that that will be valuable to them. And I'll certainly take this on to our postgraduate meetings to see how can we engage better. And Ellie Hoddesall, who is not here today, but is my sort of counterpart in the undergraduate world, I'm sure will be very interested in this, and I'll have a word with her and see if we can do as you say, try to give you that stall, give you that voice, give you that box on which to stand. So thanks very much. If there's no other questions, I will draw things to a conclusion, and thank Vinita again for speaking. And before I go, I have 2 blank weeks. Nothing booked into Grand Rounds. The first time in 10 years I've had to say that there's no Grand Rounds next week. And if you have a talk in your back pocket, if you want to just have 20 minutes, an hour to talk about your latest research or whatever you're interested in, development in your service, or anything that's your personal soapbox, then please get in touch, because next week we've got an empty slot, and the same the week after. So thanks again, Vinita, and I'll see you all again soon.